There's growing interest in focal therapy as an alternative for prostate cancer treatment. Focal therapy sits somewhere between active surveillance and the more traditional treatments of surgery and radiation therapy. And the goal here is to just treat the tumor and leave the rest of the prostate alone. This is something akin to a lumpectomy for breast cancer. And the idea is using an energy source. The ones that we typically use at UCSF are either cryotherapy, which is using ice, or HIFU, using high intensity focused ultrasound to heat prostate tissue to the point where it cannot survive. There are many others out there. There's irreversible electroporation, there's photodynamic therapy, there's interstitial laser. There are many ways to destroy prostate tissue. The key question is, do we have a good sense of what part of the prostate we need to destroy? So a good candidate for focal therapy is somebody who has not low risk cancer, because that really should just be followed with active surveillance, but with an intermediate risk cancer, typically a Gleason 3+4, grade group 2, or maybe a small volume 4+3, which is visible on imaging on either ultrasound or MRI. So we can define a target with no more than minimal cancer elsewhere. So it is okay to have a little bit of 3+3 that we're not going to treat, but we do have to have some sense that any of the high-grade cancer we can treat within a zone of ablation. There are many details in terms of just how much of the tissue we can ablate versus not, and where the tumor is and how large it is going to drive questions about what the risks of side effects are. The tumors may be right next to the nerve bundles, in which case the nerves are at some risk, although most men who have good sexual function going into ablation maintain their erections after the procedure. Other tumors which are very close to the urethra may not be suitable because there's a risk of damaging the urethra with focal therapy. So it really does depend on the details in terms of who is a good candidate, but this is something that we're using more and more at UCSF these days.